And so it's not licensed for use in trauma. So I thought, well, let's get them to license it, you know. So this is the chief executive of Pfizer. Pfizer make tranexamic acid. So I wrote to Pfizer and I said, well, when I say I wrote to Pfizer, that's an understatement. I interacted with Pfizer over a period of 2 years to try and get them to license tranexamic acid. And the way it works with drug licensing is this. So Pfizer didn't invent the drug. It was invented by Japanese researchers in the 60s. But they gave the rights to it to a company called Mitsubishi. Mitsubishi was taken over by Pharmacia and Upjohn, Upjohn was taken over by Pharmacia and Upjohn was taken over by Pfizer. So Pfizer now are the license holder, but by this time it's a generic drug, so anybody can make it, right? So anybody can make this drug. Now, Pfizer, to get a license for its use in trauma, has to make an application to the FDA, and it has to make an application fee. And the application fee is about $1 million, yeah? And so it has to invest $1 million, and it has to invest some money to get the staff to put all of the data together. And it decided that the return on the investment was too low and it wasn't going to do it. You know, it's like, well, we've got to invest maybe, $1 million to do this, and it's a generic drug, and it's not worth the money to do this. So then I thought, oh, damn, Pfizer won't do it. I tried to do all sorts of things. I tried to shame them into doing it because at the time, American soldiers were dying in the war in Iraq and Afghanistan, and so I said, look, it's like I wrote to President Obama and everybody. I said, write to President Obama, copy to this man, and saying it's disappointing that Pfizer's not going to do, and this guy was cleverer than me. He was really clever because what he did, he put somebody, he allocated somebody to take care of me. And he allocated this very nice man that I had monthly teleconferences with for 2 years, who said, yes, we're very interested in your treatment and we're going to apply for a license. And we've just got to do various different steps. So, he asked for this information this month and this information next month and this information the next month after. And he went on and on and on and on. And for 2 years, and I said, come on, what's going to happen? Surely we're going to make the application now. He said, I'm terribly sorry, got bad news. At the end of this 2-year process, he knew from the start, I'm sure of it. He knew. They were so clever. They just managed me. They didn't want me writing to President Obama, copying it to the chief executive of Pfizer. So they managed me really well. I'm very impressed by this man. Don't like him. Don't like him, but I'm impressed by him. So they're very clever in ways that academics are not. I wanted NICE to put it in NICE guidelines. And NICE couldn't put it in NICE guidelines because you can't, by law, you can't put anything in NICE. I should say what NICE is. It's the British government sort of treatment, guidance about how you should use a treatment. And so it's very influential because lots of other countries around the world look to NICE guidelines to be influential. To decide what should be in their guidance. But NICE couldn't put it in guidance because it was not licensed for that thing. So the Pfizer problem was getting in the way again, and I couldn't solve the Pfizer problem. So I started doing the same thing in the UK. I started writing to the Prime Minister, copying to NICE, and eventually something did happen. They made a way where NICE could make a recommendation of something, even though it wasn't licensed. And tranexamic acid was the first off-label evidence. So that was good. That was a small advantage. And then we had another good thing going. We worked with victims organisations. So in the UK, we're very much encouraged when we do research to work with the people who suffer from that problem. Yeah, and sometimes now you can't get research money from the British government unless you're working with patient groups who suffer for that problem. So if you wanted to do work on depression, you'd have to work with, groups of people who represent depressed people or depressed people themselves. So we worked with Road Peace, and it worked very well because Road Peace, it's an organisation of family members of people who have been killed on the roads. And so they're very, very motivated so that no one else dies on the roads. And so they wrote to all of the hospitals in the country with freedom of information requests saying, can you tell me how many of your patients were treated with tranexamic acid in the last year? And of course that's very powerful because you get a freedom of information request written to the chief executive. And the chief executive thinks, well, what's this? What is this drug, tranexamic acid? I've never heard of it. And so they talk to the emergency department. How many patients are using tranexamic acid? Well, we don't know. Well, find out. So it was very useful. And they started doing this every year to all of the hospitals in the country. Every year, freedom of information request. And slowly, the numbers of patients that were treated went up and up. But another good thing happened. And it was this. Well, it's a bad thing, but it's a good thing.
It's a fact of war. Many injuries suffered on the battlefield result in severe bleeding. Stopping it.
Oh, sorry, I tried to raise the volume there.
Is key to saving lives. So the discovery that an old drug can perform new tricks is great news for military personnel.
There was a recent trial carried out by the London School of Hygiene on topical medicine, which was sponsored by NIHR called Ch.2 trial. And it looked at the introduction of something called tranexamic acid, which stops clots breaking down. Within weeks of that trial delivering its results, we now use that as part of our treatment process.
So that was very good, right? So there was a war in Afghanistan. The British Army starts using tranexamic acid in Afghanistan. So that's very good propaganda because emergency physicians, at least in the UK, they look up to the army, right? So if the army doctors are using it, they think, whoa, this is a really good thing. We should be using it too. So the army doctors started using it in Afghanistan, and that strongly encouraged British doctors to see it as, a good, sort of sexy drug. The army's using it, we should be using it too. So that helped a lot. The best army, no, it's not the best army. If you want an army to be using it though, you really want the US Army to be using it because US Army influences all of US healthcare and US healthcare influences a lot of the world. So I've been to, when I was doing the trial, when we were doing the Ch.2 trial, we worked in Latin America and all sorts of places. And you would get American doctors talking about, giving lectures about how to manage things. And they would go like this. In Boston, we do this, right? And you don't need any more evidence than that, If they do it in Boston, it must be a good thing, So they weren't showing you randomized trials, I didn't see any randomized trials, and I was sitting there at the front listening, where's the randomized trials? And they just say, this is what we do, right? This is what we do, and that's it. That's all you need to know, doctors in Colombia, is that we do this. And therefore, the implication is that you should do that too. So I don't like that, but if you can get the US Army to use something, then it sort of has a big effect around the world. So we tried to get the US Army, so the British Army were using it, so we said the US Army, you know, why aren't you using this? It could reduce death in your soldiers. And they had a meeting in Washington. So eventually they had a meeting in Washington. They invited me to this meeting, and I thought, and it was a meeting of military medical people, and you know, they had all of these uniforms on, and they have these things on their shoulder, you know, big things. And I thought, how do you convey a relative risk of 0.7 to a military medical, you know, a military medical doctor? Because they tend to be surgeons, and surgeons are less interested in epidemiology. And you know, this kind of black and white. So I went to, this is Arlington Cemetery. Arlington Cemetery is the cemetery in Washington where they bury people who have been, bury soldiers. It's a soldier's graveyard in Washington. And I found this special plot of land where they bury soldiers who are killed in Afghanistan. So I took a picture of it, and it just happened there were 100 graves on that, there's 100 graves visible there. And so I said, this is a relative risk of 0.7, you know, that's a third reduction in deaths. And they liked that, right? So that they could get that. They still weren't an easy audience. I remember there was this one guy, he was the sort of chief, I don't know, he was quite a senior guy, and he was huge, and he was the most hairy man I've ever seen. He had, you know, he had his shirt and tie on like this, but there was this hair just flowing down here. It's like a waterfall of hair. And I just thought, my goodness, this guy is such like, whoa, you know. And I thought, I tried not to be influenced by his manliness, you know. But at one stage I stood up and said, he said something, this guy, this colonel said something. And I said, well, that's not true. And he just pointed at me, he said, Roberts, sit down. And I thought, wow. And I thought, what do I do? Do I sit down? But I've never, you know, it was kind of a different currency. In the university, we don't really do that. We don't use our manliness or our womanliness on our colleagues like that. But this is obviously what they do in the American army. Roberts, sit down. So it turned out that I couldn't persuade them with a randomized evidence. So they decided to do a study of their own, right? And what they did is that at that time in the war in Afghanistan, in this Camp Bastion, Camp Bastion is like, there was this big hospital in the desert in Afghanistan. And if everybody, all of the soldiers and the civilians who were injured in the war came to that hospital. Now, if you came to that hospital, you were either seen by British medical doctors or American doctors. If you were seen by British doctors, you got tranexamic acid. If you were seen by American doctors, you didn't, right? Because they didn't agree, right? British doctors were doing it. They were very at war about this treatment, right? So the American doctors didn't like it, the British doctors did. So if you were seen by a British doctor, you got it. So they decided to do a cohort study, right? Comparing those who got tranexamic acid with those who didn't got tranexamic acid after controlling for severity. Now, this is completely not the right way to evaluate treatments. Risk-adjusted cohort studies are not the way to see if treatments work. But luckily, they got the right answer. They got the right answer because we know what the right answer is because we did a big trial. So they did a cohort study, and they found out that actually the patients who were seen by the British doctors were sicker than the patients who were seen by the American doctors, but still they were less likely to die. So if you got TXA, you're much less likely to die than if you didn't get TXA. And so they believed this because this was their own data. Now that's a very strange thing, you know. It shows you how how strange we all are that, you know, if you get a randomized trial with 20,000 patients and a very clear reduction in mortality, and it doesn't vary by location, people don't believe it, but they will believe their own data that's much, much inferior. You know, that's just the way it goes. So they started believing this, and we were also doing other propaganda things. So, for example, I wrote to, on the anniversary of President Kennedy's death, right? So President Kennedy was president of the United States who was shot, and I wrote to all the presidents in the world, and because it's very easy to do, you know, you write to all of the presidents in the world and you say, look, being a president is a dangerous job, you know, and so you might like to make sure your personal physician knows about tranexamic acid. In the US, it's a really dangerous job being a president. Of the 44 presidents, I mean, I think there might have been 46 by now, but you know, out of 44 presidents, when I last counted, 11 of them had been shot, you know? So that's 1 in 4 of presidents get shot. It's a very dangerous job. So I wrote to him and I said, look, you know, you should be using tranexamic acid. I thought I'll never get a reply. I didn't expect a reply. But then I got this email, and this is what it said in the sender address. It said, AF1 en route home from Kabul. So President Obama had just been in Afghanistan, and this was a message from Jeffrey Kuhlman, who's his personal physician. And he said, the WHMU, the White House Medical Unit, utilizes tranexamic acid in our operations and planning. Thanks for the information. I thought, wow, what a, whoa, that's a publicity coup, right? So then whenever, you know, when these generals said, sit down, Roberts, I said, well, it's good enough for your president, you know? And so that was very good, so that we could use this information to say, well, look, you know, whenever I'm at a meeting, I say, well, President Obama uses it, you know. President Trump's personal physician will use it. You know, aren't you using it in Denver? Or, you know, San Diego or wherever. So that was very good. Also, yeah, I told them all about, and the interesting, apart from the United States, I got a letter from his personal physician, but I got letters from lots and lots of presidents or their personal secretaries. And they write back to me and say, thank you very much for this information. We've passed it on to his either the personal physician or the Ministry of Health. So it turned out to be a very good way of getting this on the agenda. We've done it for all of our trials subsequently. We just write to the president, and then the president sends it to the right place, usually. But we still had a lot to learn about how to get research into practice. And we started studying the pharmaceutical industry, because the pharmaceutical industry are the experts of getting research into practice. When we think of the pharmaceutical industry and what they do, they would like us to think that they invent clever treatments. That's what they want us to think. That's not true. Clever treatments are invented in universities. What the pharmaceutical industry is really good at is marketing, right? So if you want to know about drug development, go to the University of Kyoto. If you want to know about marketing, go to Daiichi Sankyo, yeah? So pharmaceutical companies know about marketing. Now, there was this drug at the time that they were using in Afghanistan called Novo-7, right? Novo-7. It was a blood clotting factor, activated factor 7A. It wasn't it wasn't effective at all. The randomized trial showed it didn't work, and it was associated with significant side effects. So it was a dangerous drug that didn't work, but everybody was using it. It was very expensive, $7,000 per treatment. But you could not die of hemorrhage in the UK without getting this first. It didn't improve anything. It didn't improve outcome at all, but everybody was using it. I just thought, well, I'm going to study the pharmaceutical industry because how can they do that? You know, it's an ineffective drug. It's not licensed for that indication, and everybody's giving it. I've got an effective drug that's not licensed for that indication, and nobody's giving it. Well, they're only giving it slowly increasing giving it. So I started to study them. And I realized that they don't worry about trials. They tell stories. They tell stories. So this was one story. This was a commentary in the Lancet, right? So it was a single case, and it was a commentary in the Lancet. A 19-year-old soldier was admitted it came from Israel. A 19-year-old soldier was admitted with a high-velocity rifle injury. The bullet tore into the inferior vena cava at level 5, causing extensive damage to paravertebral muscles at the exit wound. He was admitted in a critical condition with profound shock, right? Now you can imagine him, right? You can imagine him in a desperate attempt to control the bleeding. 60 micrograms per kilogram of recombinant factor 7A were given intravenously. 10 minutes after the injection, coagulation tests improved, reducing the rate of the bleeding. He survived, right? So this was a guy, a single soldier, shot, given this drug, miraculous recovery. Absolutely no evidence. That's not evidence of effectiveness. That's a story, right? He could have been, you can't say anything about the treatment effectiveness from that. But this story just spread all around the world. I would go to conferences. This particular soldier, I went to a conference in China, and there was the stand of this company had a picture of this 19-year-old with his wife and his baby. And this story just went everywhere. It went all over the world, I thought, wow, that's the way to do it. The only thing that will spread information is stories. Story is the only way to disseminate information. And then this was sheer genius. And I really respect the pharmaceutical industry for how clever it was here. Oh, I should tell you what this... anyway, listen to it first.
No, it saved my life. When I was shot, lying there on that road, I was so scared that I would die. And then they came. They risked their lives, scared me. They gave me factor 7A. And it stopped the bleeding. I can't sue them for that.
Okay.
So this is a emergency medicine soap. We call them soap. I don't know what you call them in Japan. Like they're serials. They happen. You follow a story, and the story was that this woman soldier got injured in Afghanistan, and they gave her tranexamic acid. How did they get that on national television? I thought that is brilliant. I want to be able to do that. That's the way. Don't bother with medical journals. Get it on the television. It was so clever.